I'll now request Dr. MINU M.MATHEN. He's a consultant cataract surgeon from Chaitanya Eye Hospital in Trivandrum. Has had his post-graduation and training from Aravind Eye Hospital, Madurai. Again, a very experienced cataract surgeon in all forms of cataract surgery, small incision, manual small incision, phaco, femtosecond, and is a chief instructor in many courses in ASCRS and in our All India conferences. So over to you, Dr. MINU.
Thank you, Dr. Ashok, for this opportunity. So I would talk on phacoemulsification in subluxated cataracts and small pupils. So one thing we should know about is using capsule stabilizing devices. So I would take you to capsule tension ring first. So is my sound okay, Ashok? Is my sound okay, or is there any lag?
There was a little lag. I don't know if it's to do with the connectivity.
Okay, now that was maybe because of the. Now it is okay.
Yeah, now it's fine. Clear. No, it's breaking again. The voice is breaking.
To inject the.
We are not able to hear me, no?
Ring.
Not good.
I usually make a comparison. This is opposite. Yeah.
MINU, we are not able to hear.
To hear you.
Sir, आप अपना वीडियो कैमरा ऑफ करके
Video is also not moving.
वीडियो ऑफ कर लीजिए, आप अपना नेटवर्क लो है.
He's coming back, is it?
I'm hoping, yes. I'm trying to get across to him.
Sir, so we don't have any other presentation, right?
This is the last. Yes.
I think, yes, we should wait. So by the time if the sir is coming back, why don't we have some exchange of questions or something?
Yes. So no, I just have one. Let me make the beginning. To Dr. Sagar, I was wondering, Sagar, would you have done a PK with a cataract in that patient? Or
that would have been a good option, no doubt, but he was not in a mental state to have such a complicated surgery. His only concern was that it should be just be ambulatory as of now. So we did discuss with him this issue. He said, let me have the cataract surgery first. Let me see how ambulatory I become. And after that, I can always take a call. So what I realized is that on slit lamp with the retroillumination, I was able to see the cataract quite well. So I thought it's a doable surgery. So that's why I took it with a nice retroillumination.
And just one more question, Dr. Sagar, regarding your side port incisions that you made. Do you make a special choice of where you're putting the incisions? I noticed that you put it in between the two incisions, that arcane incisions. But there's always a risk that it can extend and open out the incisions. Do you have? I mean, have you considered doing a little bit more scleral or near?
Yeah, I have done 24 cut RK also. So in those cases, I go a little posterior. Now going little posterior again is a two-edged sword thing, because you can start getting iris prolapse there. That's the big problem. So I try to do it in 20 cut in between the two things and see with minimal possible entry if I can able to manage. So, but I agree with you. In 24 cut and in a higher cut, it is difficult. Yes.
Very well done surgery.
Can you see mine now?
Yeah,
Yes.
clear.
Okay, sorry, very sorry about that. Somehow it got cut. So, capsular tension ring. We'll
Sorry to
continue
interrupt.
with this.
Sorry to interrupt you.
Go through the
सर आप अपना
paracentesis.
वीडियो कैमरा ऑफ कर लीजिए.
Make sure that the leading eyelid goes. Last time I tried to switch off my video camera and the whole thing got disconnected.
No, now the
Stop
voice
video.
is clear.
Okay, I think I'll just keep it on like that. Otherwise, everything will get cut off.
No, now it's clear.
Okay.
To switch off. To switch off other people's video camera, it will be better.
That's what I'm trying to do. On my video, mute is there. Okay,
Yeah.
that's gone now.
Yeah, there you go. You are fine.
Fine. Okay, so the paracentesis, if you can notice, the pressure of pushing the CTR is at the edge of the paracentesis. That is another crucial point, so that it moves smoothly into the capsular bag. And the tip should not press against the equator. That is one point which we need to make sure. And once it travels, we can use a second instrument through another paracentesis to guide the trailing eyelet, or we can use a microrhexis forceps through the same paracentesis here and get the trailing haptic directly into the capsular bag. So we should make sure that the lens CTR has gone into the capsular bag. So once the capsular bag is fixed, so here the first thing I do is to identify that there is no vitreous here. So if there is vitreous, we got to do a limited vitrectomy so that the AC is clear of vitreous. But then if you do too much of vitrectomy, the lens will become more unstable. There won't be much support. So vitreous should be there to support your lens. And then I put viscoat. Viscoat is the one which will plug that area, no financial interest in that. And then put HPMC or even cohesive viscoelastic if you want over it. And after that you do a rhexis which is centered to the bag, and then I use iris hooks. I like iris hooks. Capsular hooks can also be used to support the bag, and then this is the way you put it in through the main incision also. It's possible. And after that we use low parameters. So bottle height not to have surge, and your irrigation and aspiration and vacuum all should be low, so that slow motion phaco happens here, and enough energy for the particular nucleus which you are doing. No point in reducing your energy too much, because you have to cut the nucleus which is has to be cut without difficulty. So the technique, we can use the same technique. I use my same regular technique like initial burrow and then chop, and we realize that even after hydrodissection, the initial rotation will be slightly difficult because some areas of zonules are not there. So it has to be very gently done, and make sure you irrigate, you hydrodissect well, and then rotate well. Once the nucleus is emulsified, the main point is not to shallow the chamber. Do not take out the irrigation, fill the bag, and then take out the irrigation. IA is difficult with the CTR in, because it can trap the cortex between the capsular tension ring and the equator, but then it can be accomplished slowly and by tangentially pulling, not directly pulling towards the center of the lens. So you can place a single piece IOL in the bag, or a 3-piece IOL in the sulcus, and capture it onto the rhexis margin. So femtosecond laser in subluxation is very useful, because see, notice the rhexis can be positioned away from the area of dialysis. If you can notice here, the dialysis on this side and the rhexis is eccentric. The lens is now placed centered to the bag, and so that you have anterior capsule enough here to later support it with the hooks, or the IOL placement can be easier if you locate the rhexis little away from the area of zonular dialysis. So here it's a long-standing dialysis, very soft cataract. I proceed without a CTR first, because the bag is very stable, no vitreous inside, very soft cataract. It's prolapsed into the anterior chamber first, and the whole procedure is completed. Towards the end of the procedure, after cortex aspiration, I can inject a capsule tension ring into the bag, and now I see some folds here, which I thought initially was a capsule tear, but actually it was just tension lines, and also a fibrotic band which was behind the PC because of the long-standing trauma and the capsule fibrosis, and the case ends well. CTR, as we know, initially you can place, but you can delay it also. You see, in such a case where the whole bag is very wobbly, see, you touch the lens, it moves in all directions. So here, initially itself, if you try to place a CTR, especially when the nucleus is harder, it may be quite difficult and it may damage more zonules. So here, after a rhexis, very difficult it is to do a rhexis, but then if sometimes you may need a bimanual technique to do a rhexis. And after that, I support the bag with hooks. So iris hooks works very well for me, so I use only iris hooks. There are capsule hooks which can even extend up to the equator and support. And then after cortex removal, I get the CTR inside. Sometimes cortex removal will be difficult because the bag may move towards, along with the cortex, the bag may be moving. And at that point, you can even place an IOL and stabilize the bag, or at some point, you can have the capsular tension ring inside and aspirate it very gently. So when there are subluxations more than 180 degrees, and if you think that it's a progressive subluxation, you use scleral fixated fixation devices along with the CTR. Here it's a CONE modified ring. So here there's a very subluxated lens, and it is the rhexis is being held with the hooks now, and the CTR goes inside, and there is an eyelet and a hook which is at an elevated level, and that is retained above the rhexis margin. The ring goes into the bag, and this remains above the rhexis margin, and it's rotated into the area where there is maximum subluxation, which is here. And before introducing this, the eyelet is threaded with the 90-proline. I have not used Gore-Tex till now because Gore-Tex is the one which will remain for life. And once that is done, these two needles which are outside the incision, I am taking out through a paracentesis which is opposite here. This is for convenience. And just like the scleral fixation, the needle is passed under the flap and the needle is taken out above the capsule. And then these two needles of thread of the 90-proline is threaded out, and the eyelet is tightened. You don't pull too much, it is just to center the bag, and then the suture is tightened onto the scleral bed. And there are segments also available. These are much easier to implant. The other one was quite difficult to implant, and so I don't use them anymore. I use only segments, Ahmed segments. Here it's a gross subluxation, very long standing one, and after the lens removal, I place in a capsular tension ring and see whether the bag is getting decentered. The bag was relatively okay centered, so I then see whether the IOL will be centered. But after placing the IOL in the bag, the whole bag IOL complex is definitely decentered and is not well centered. So I create a flap here. You can do away with the flap. You can do a Hoffman's pocket without dissecting the flap or the conjunctiva. So this is about 1/3 of the ring, and with the eyelet and the hook, which is similar to the one on the ring. And the 90-proline is threaded into the eyelet, which is there on the segment. And this is made, I buy it from Orolab, no financial interest in that. And the segment goes, already there is a ring inside, and the segment is again positioned into the bag where there is maximum subluxation, and this eyelet remains over the rhexis margin. And after that, like we saw before, the two needles are railroaded through the 26 gauge needle, which is taken above the bag. That is very important. Both have to come above the bag, and the sutures are tightened so that the bag gets centered well, and the flap is also closed, and you can see that the lens gets well centered with the eyelet being hooked with the thread here. So we move on to the next topic of small pupil. There are enough techniques of not using any dilating devices. I am not going into that. So if you are comfortable doing a 4mm pupil, if you can do a rhexis 4.5, then if you want to continue, please do continue. But if you are not comfortable, if you cannot do a 4.5mm rhexis, I would prefer to use dilating devices. So iris hooks are very commonly used. Nothing should be against iris hooks, because we should realize that these incisions are very small. See, the type of the hooks which you buy also matters. But then I don't have any financial interest. Alcon used to make very, very thin ones. They have stopped making it now. So Orolab now makes, which is similar to that. It goes in through very small incision. You don't have to make it very large. See, don't let the paracentesis go. This is a 26 gauge needle. You make an incision with the 26 gauge needle there, and I'm just comparing the other incision here with the 26 gauge. It doesn't go inside. So that is smaller than that, but your ring, the hook goes in through that. So don't hesitate to make incisions for this. They will close by themselves, and there's no problem at all. Here is one case, post trab and a small pupil with this fibrous membrane at the pupillary margin. So release most of these fibrous membranes and the posterior syncytia. Once you release this, the pupil becomes more free. Otherwise, they tend to tear more when you try to stretch them. See, they move it in the direction very atraumatically. Don't pull too hard towards the center. Otherwise, sometimes it can cause even iododialysis. But then, in a tangential manner, if you pull gently, it comes off fully, and then you get a very free one. So again, I prefer to use 5 or even 4 with one sub-incisional. So, and you can notice the stretch between two hooks are much lesser if you use 5. And sub-incisional again helps in preventing dragging of the iris when you are introducing the phaco probe and all those. And here again, it's not pulled towards the angle, still the angle. See, it's just a 6 millimeter opening so that you can completely do your technique. So it need not be completely pulled towards the angle. That is what is most important. And the incision should be made as a stab incision and not going through the cornea 1 millimeter and then entering. Then you will pull up the iris too much and you can crowd the anterior chamber. And also the incision must be close to the limbus. And if you are cutting through the conjunctiva, then sometimes it will leak and it can balloon up the conjunctiva and you can have fluid collecting within your area and over the cornea, and it can cause difficulty in visualization. If you cut through conjunctiva while placing the hook, please do a snip on the conjunctiva so that the fluid doesn't collect subconjunctivally. Here I am showing you a Malugin ring. So here posterior sanic is released and visco is placed under the iris. That is very important. So then 2.2, it goes in through a 2.2. The leading scroll is engaged in the pupillary margin, and you can place this towards the side and tilt and engage two of these also in the first shot. May not happen all the time. And the fourth one can be left there. Need not push it too hard. Just pull the iris towards you and then engage. So you can get a 6 millimeter opening. And after you finish your regular phaco, you can release one scroll and the rest can be pulled out very gently. And they can be pulled out just with the forceps. Or if you want to reuse, you can ETO it and reuse once. Or I have used it twice and the second time it broke at the connection. There is a connection. If you notice here, this is the area where these two ends are connected. And if you open, close 2-3 times, it is made to break so that it is not reused. So it is not free of complications also. It has a learning curve. So, see, when you do it on a 2 millimeter pupil, please do stretch the pupil a little bit and make it 2.53 millimeters. Then try to implant any ring. So here you can notice that it is difficult to engage the side scrolls because the pupil is not big enough. So we are made to leave the whole thing free in the anterior chamber. That's okay. But then here, see, this is the original version where it was difficult to sometimes release off this hook. The injector has now been modified. The 2.0 has come, and they are more easy to release it. And sometimes it gets so stuck that you need a second instrument to release the trailing scroll from the injector. And once that is done, we can use either a forceps or a hook, Coughlin's hook or a blunt one to engage the scrolls. Because the pupil is so small, we will be focusing on the scroll and the pupillary margin. We may skip the focus on the anterior capsule and you may touch on the anterior capsule. You can have capsule tear because of the sharp Sinski which you may be using. So I tend to use a Coughlin's hook with blunt edges. And again, as I showed you last time, lift up the hook, the ring, and then pull the iris back and then engage the trailing, the fourth scroll. And after that, while releasing also, please make sure that you pull on the scroll alone, not to engage on the iris also and pull. Sometimes you can engage on the iris also and pull, and you can get an iridodialysis when trying to disengage these scrolls. So coming on to the last one, this is the Hex Pupil Expander, our own Indian one, Suven Bhattacharya's one. This is a very useful, very user-friendly one. And I'll show you, this is an IFIS case. So you may think that why would you need, this is a 4 millimeter pupil, you can always tend to do it without that. But then I'm sure that it is going to come down in size during the procedure, and that's why I put iris hooks in the beginning itself in all IFIS cases. Iris hooks or rings. And this is not the latest version, this is one version previous to the latest one. That's why it doesn't have 3 of those rings. But then alternate flanges are tucked underneath the pupillary margin. And once that is done, you use a forceps. Now we don't recommend for Sinski hooks or the manipulator. Please use flat tipped. This is not the one which is regularly used for the ring, which comes with the ring. It's a sharp tipped one. Don't use this. flat tipped ones have to be used, and holding it from paracentesis, make 2 paracentesis and put the visco underneath the iris as in all rings, and then engage it. And here again, if you have noticed, I have touched the anterior capsule with the Sinski, because I was using Sinski there. So all the flanges, please engage with forceps, and that is the easiest one to do. You can, this is a 5.5, this looks smaller, but 5.5 which does not come down during your surgery is what is required, and that will give you the confidence to complete the whole case without any problem. At the end of the surgery, you can implant the IOL, but while implanting the IOL, make sure that the leading haptic goes into the bag, and the IOL optic also goes into the bag, and the trailing haptic clears the ring. That is very, very crucial. Don't place it over the ring and try to dial. Sometimes you can involve the ring also when you are dialing it. And once one flange is disengaged, you can pull it out. It even comes through a 1 millimeter opening. And that's it. Thank you very much.
Thank you very much, Dr. Minu. Excellent videos and presentation as always.